Let's see what that does. Lee, do you want to maybe also record, but record to your computer, just so if my cloud doesn't actually exist, we have a backup? Thank you so much. All right, so welcome everyone. It is an absolute pleasure to see you all and to have had so many of you join early. That's a first. Before we get started, let's just dive into a bit of housekeeping. I know none of us are new to Zoom, but there are some tips and tricks to consider for this particular session. Firstly, it is always really lovely to see human faces. So if you are comfortable doing so, please do turn on your video. Do note though that this session is being recorded. And because we really wanted this hour to mimic as much as possible what it might be like to be in person today, we elected to not make this a webinar Zoom format. Rather, it is a meeting. So that means that all of you can engage. That being said, it would be great if you all stayed muted unless you are speaking or posing a question though. Feel free to use the chat box as much as you want, and the Zoom emojis. I always love seeing hearts and thumbs up flying by. And for the best experience, I would suggest that while speakers are participating in the panel, that you put your Zoom view into speaker mode. And to do that, you just toggle to the top right of your computer and it should have a view option. Click on it and you can either select speaker or gallery. And you'll be able to see the difference really quickly when you do that. So speaker mode would be my recommendation for today. Okay, so I think we are all set to go then. So we are gathered here today because World Tuberculosis Day is coming up next week. And Amal, your student peer, who you will meet in a moment, took the initiative to take action to stand in solidarity with those affected by this infectious respiratory disease. Before the start of the pandemic, TB was the leading infectious disease killer in the world. In 2019, about 10 million people fell sick with the disease and an estimated 1.4 million died. We know that because of COVID-19 lockdowns and disruptions, many more people will die from tuberculosis. And it is absolutely heartbreaking to witness that health systems around the world, including here in Canada, where I'm based today, were not equipped to respond to an emergency and maintain essential health services. The reason for this has largely been that governments have long neglected investing adequately to put the health of their people first. And that's just not right. TB has existed for over a century, and it is still present in every country in the world. In today's panel discussion, you will learn from experts about how the TB response has been critical to the response to COVID-19, how the pandemic has impacted the TB epidemic, and what we can do to take action to end both TB and COVID everywhere. So let's get to know our speakers a little bit first. I'll kick things off and then I will pass the baton over to Amal. So for those of you who don't know me, my name is Dr. Robin Waite. I am the Policy and Advocacy Manager for Results Canada, which is a not-for-profit organization on a mission to generate the political will to end extreme poverty. I'm also the Secretariat at Stop TB Canada, where I'm working hard alongside partners to reinvigorate and mobilize a community of Canadians committed to ending tuberculosis at home and abroad. All right, over to you, Amal.
Great, thank you. Hi, everyone. My name is Amal Abdurrahman. I'm a fourth-year global health student at York University, and I'm specializing in health systems, health management, and global health policy. This term, I've been working alongside Robin as an intern at Results Canada in the area of tuberculosis, and I've also been working alongside her at Stop TB Canada. And I'll pass it along to Dr. Daftary for her introduction now.
Thanks, Amal. Hello, everyone. Thank you, Amal and Robin, for inviting me to this panel. It's a real honor to be among such esteemed colleagues and to have such a great audience. I'm on faculty at the newly established School of Global Health here at York. I also hold an adjunct position at the Center for the AIDS Program of Research in South Africa and at the Dalla Lana School of Public Health at University of Toronto. And it's really great to see so many friends from... Sorry. Am I audible?
Yes, sorry, keep going.
Oh.
If anybody else like unmutes, don't worry. We'll rush to mute speakers.
Okay,
So
sure.
sorry
No,
about
no,
that,
no.
Amrita. Go ahead.
Thank you. Thank you. It's also really good to see so many faces from McGill, where I was for a few years. Hello. I've been working in the TB space, I guess, for now about 15 years, using a social science lens, starting with graduate school in New York and a first trip to South Africa, where I learned about some of the social impacts of the disease quite clearly and harshly. Much of my research is rooted in qualitative methods. I study TB stigma, health-seeking behaviors, and try to inform sort of person-centered approaches to care for people with TB, particularly in the context of HIV, illness, and drug-resistant TB. I continue to work in South Africa, including with Tumi, who's going to speak soon, and contribute to several projects in other parts of the world as well. I'm very, very excited to raise awareness about this problem, particularly to the York community and to all of those on Zoom today. Thank you.
Great, thank you. Now, Dr. Mehta, if you can introduce yourself as well, that'd be great.
Yeah, thanks, Amal, and thanks, Robin, and the other panelists. It's great to be here in the company of people working on TB, because I've been doing TB for many years. I'm Dr. Firdosi Mehta, a public health physician with over 35 years of experience in different countries across the world, more than half of which has been with the World Health Organization. I am origins are from India, where I was in the armed forces for about 11 years, then moved to Oman for 10 years in the Ministry of Health over there at central level as the Director of Surveillance and Disease Control, where my public skills were honed. And then I got an entry into WHO and started in Somalia, based in Kenya, and worked in Somalia for about 4 years, doing as the country TB advisor in doing TB work in a complex emergency country, which is a completely different ballgame, and that can be a different webinar altogether. From Somalia, moved to Indonesia, and I was there as the country advisor on TB for 7 years. And I'm very happy to see my dear old colleague, Petra, who I haven't seen for over a decade. We used to work together in Indonesia, and I worked over there for 7 years. Then I moved to Sri Lanka, and I moved there as the country representative of WHO for 6 years, and that was one of my best appointments. And I've been in Canada since 2014 as an adjunct professor in York and the Dalalana School of Public Health. I do mentoring in York and on different platforms, and I'm very happy that Amal has taken this leadership role in organizing this webinar, and I'm very happy to see that. So thank you for being here. Thank you. Over to you.
Thank you, Dr. Mehta. That was a great introduction. Now for our last speaker, Dr. Seepamore, if you could introduce yourself, that'd be great.
Thank you so much. Good evening, everybody. My name is Boitumel Seepamore, or Dumi, from the University of KwaZulu-Natal in Durban, South Africa. I'm a social worker qualified from the University of the Witwatersrand, or commonly called WITS, and where I also obtained my master's in occupational social work. And my work experience, I have mainly worked in the HIV/AIDS field, and I started working in a rehabilitation unit in Johannesburg, and since then moved to different organizations, one of which was the perinatal HIV research unit. And I'm so excited to see colleagues from the city of Johannesburg, where I worked as a researcher in the Office of the Speaker. Tate Mokgase, welcome, and other colleagues from UKZN. So I'm currently working. I'm currently working at UKZN, and I teach social work. And here I was privileged to be invited to join the praxis study, working with Amrita at the King Dinuzulu Hospital in Durban. So this is really a study that aims to promote engagement in drug-resistant HIV, TB in South Africa. And in 2018, we also were involved in a study that looked at supporting patients on drug-sensitive TB. And I'm also very excited that I'll be co-investigating a study on the psychosocial impact of COVID on HIV and TB patients. So that's where I'm at the moment. Thank you.
Great, thank you all for your great introductions. Now we're gonna go into the moderated panel discussion. First, we'll start with Dr. Mehta. From your experience working with government bodies and the World Health Organization, can you speak to what some of the system level challenges to TB control and elimination are? How might COVID-19 be exasperating persisting challenges?
Yeah, thanks, Amal. And I'll spend the next 5 minutes reflecting on my lived experience with TB in different country settings. That will be number one. Number two, issues relating to COVID and its impact on tuberculosis in terms of the person, systems, and society as a whole. So let me just start with, I told you that I started with WHO in Somalia for 4 years. Somalia, as you know, is a complex emergency country, no central governance, security is an issue. And I went into Somalia in 1998, and I was there for 4 years. So I'm happy to say that when I went into Somalia, there were only 9 TB centers. When I left Somalia, there were 27 TB centers, 1 each in each TB district. The myth that TB control cannot be done in complex emergency countries was dispelled during my work and the work of several other colleagues who had worked in the Horn of Africa. The problem in Somalia was that the populations are nomadic. So the question is, how do you hold them and how do you ensure they take treatment and they complete their treatment? So there was a system called the Damin system or the guarantor system, where a family member or a prominent person from the community would stand as a guarantor for him or her completing their TB treatment. So this was a very pivotal aspect or anchor that helped dispel the situation or the myth that TB cannot be controlled in complex emergency countries. During that time, I had the privilege of working with an outstanding person called Dr. Annalena Tonelli, who was from Italy, and she was like Mother Teresa, and she had spent her whole life in the Horn of Africa. She had a TB center in Boroma, which was holding almost 1,000 TB patients, and she did a lot of work on nomadic populations. And unfortunately, after I left Somalia, when I moved to Indonesia, a year or two later in 2003, she was gunned down by a militia and killed. So these are the realities of the world. Then I moved to Indonesia. So one thing all you participants have to understand, that TB is not uniform all over the world. You have to understand that right from the time that I joined WHO, the whole system was to designate high burden countries, and 30 high burden countries in the world constitutes 87% of the TB burden. And then there are 8 countries, of which Indonesia is one country, 8 countries, that is India, Indonesia, China, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. They are responsible for 2/3 of the TB burden in the world. So what I'm trying to say is, any progress made or any regression made in these countries has a huge impact on the global situation of TB, etc. So then the other issue is, as far as the treatment, the coverage and the success rate, etc., a lot of progress has been made. And the good news is that from 2000 to 2018, 58 million lives have been saved as part of the global effort to end TB and to control TB globally. However, there are important gaps. There are diagnostic gaps, there are treatment gaps, and there are financial gaps. One of the biggest gaps is that the number of estimated cases is 10 million. The number reported and diagnosed is 7 million. So that 3 million gap is where the problem is. And I'm happy to say that Indonesia took a leading role by doing an inventory study in 2017. This was much after I left. And they found out the various reasons why these many people were they were diagnosed but not reported. And that was one thing which was good, that even though they were not reported, they were put on treatment. But then they made tuberculosis as to become mandatorily reported by legislation. And these were some of the efforts that were taken. Now, coming down to the last part of the impact of COVID-19 on TB, I look at this in 3 aspects. 1, the disease. 2, care avoidance. 3, health service availability. And 4, the effect of lockdowns. So as we know that tuberculosis and COVID, they share similar as a respiratory pathogen, and also the response is testing, tracing, masking, isolation, and airborne infection control. So there is a lot of similarity between the two. However, there has been a lot of care avoidance for people not wanting to go to outpatients, and so that they did not want to be exposed to the virus. Stigma played a big role, and one of our panelists is going to talk about it. Then health service availability, decrease in health facilities offering TB services, reallocation of personnel and resources, disruption of supplies, and movement restriction and lack of transport. But so this has pulled back a lot. A lot will have to be sort of recalibrated. And I would like to lastly mention the role of the Global Fund against AIDS, tuberculosis, and malaria. And in Indonesia, I was the vice chair of the CCM, the country coordinating mechanism. And I'm happy to see that the Global Fund has mobilized almost $1 billion in to help countries to address the impact of COVID-19 on tuberculosis. So I leave it with that based on my practical experience and the nuts and bolts. And back to you, Amal.
Thank you so much, Dr. Mehta. You raise a lot of good, interesting points about the impact of COVID-19 on the TB epidemic. Now we'll move on to Dr. Seepamore. Through the process of your ongoing study and experiences exploring what impact COVID-19 is having on people with TB and HIV in South Africa, what are you learning?
Thank you so much, Amal. In South Africa, has a population of about 60 million people. And at the moment, we've got a 95% recovery rate, although about 1.5 million people have been infected with COVID and have recovered. So the first case was in the 5th of March in 2020, and the country was in lockdown 3 weeks later. So at the peak of the wave, in about July, we had about 13,000 new infections a day. And so the country was put on a different lockdown level. So we've got different levels of lockdown. When the numbers reduced to about 900 new infections per day, the lockdown regulations were relaxed. So just to give you a picture of what it was like for us in South Africa. And we've had a second wave, and we are also hearing of a third wave probably coming in the winter months. So the impact of COVID on patients has been devastating, especially because TB patients are vulnerable. And at the moment, livelihoods have been negatively affected. As you may be aware, we have about 7 million unemployed people. And the lockdown has meant that businesses have closed down, people's ability to earn an income has been affected. Most of our patients are either unemployed or earn low wage, as domestic workers, as street traders, or they run small businesses, what we call SMMEs. So many people also got retrenched, and they've had no opportunity whatsoever to earn an income. Food prices shot up. Patients were left even more vulnerable. So what makes it even worse is that our patients have inadequate housing. Some stay in informal settlements or overcrowded spaces, and some have no running water. So the health outcomes have deteriorated, and this has impacted negatively on TB patients. So people like Dr. Mehta has just said have been hesitant to approach healthcare settings because they fear contracting a COVID. There's also a fear of a positive COVID diagnosis. We've also seen people self-diagnose and try home remedies to treat their symptoms. So this has really affected the community and the psyche and the emotions of people. So I also have to point out that the impact has been negative in terms of high levels of depression, isolation, stigma, rejection, anxiety. This places our patients at even greater risk. So the restriction of movement has made the usual sources of emotional and social support inaccessible. We have also seen that more support has been largely virtual. So in South Africa, data costs are very high. So this has also limited access to available support systems that are mainly available through social media or WhatsApp. I also want to say that government intervention was quite swift. In 3 weeks, there were interventions put in place. We found that a national coronavirus command council had already been established. We've also had various forms of communication that were put in place. We saw a COVID hotline being established, a government WhatsApp line for more information. They launched mobile testing sites, rapid testing kits, put up field hospitals, employed more healthcare workers, implemented a massive community-based testing intervention. So there has also been a continuous education, sensitization, and destigmatization of this disease. So the mobilization of resources to fight this disease have been amazing. But can you imagine if these interventions were targeted at TB? So, perhaps another welcome and important issue is the visibility of government interventions. We've had updates, we've had frequent updates from the media, we've had real-time reporting by the president, by government, and all this is new to us since HIV. So if you ask anyone in South Africa today, they are most likely to know the current stats and recovery rates of COVID. But they would have no idea how we're dealing with the leading cause of death in South Africa, which is TB. So there really has been a focus on this new and frightening disease, and many resources have been redirected towards COVID. So let me stop here, but and I can add later if there are any other questions.
Thank you. Thank you for giving us the example of South Africa so we can understand how TB is being impacted by COVID on the ground. And now we'll move on to Dr. Daftary. As your expertise is related to TB stigma, can you speak to the parallels between TB and COVID stigma and how this may be impacting people's access to TB services? How do you think this type of stigmatization can be addressed?
Yeah, thanks, Amal. I think I can piggyback on several of the responses already sort of gathered during this talk. There are so many parallels between TB and COVID stigma, and I'll maybe touch upon some of the main drivers of stigma and TB, because I think it'll be very quickly to see the overlap and relevance for COVID. And I'll talk about three levels of drivers. And I think at the most obvious, sort of simplest level that we can all connect to is that TB stigma is transmissible, right? And TB stigma is connected to that transmissibility of the disease. It's contagious, and the risk of death and debilitation is very real. So it's not surprising that people are afraid of TB. And this fear sort of drives this impulse to distance ourselves from a patient, an action which is immediately exclusionary and discriminatory. And we see this with COVID, which is also a contagious disease, in fact, more so than TB. But at a more sort of insidious and underlying level, the stigma of TB is rooted in sort of the social inequalities in which it comes about, right? Who is the face of a TB patient? It's people who live or were born in poorer countries, people who work in compromised conditions, people who are homeless or living in slums or overcrowded housing, people of color, people with HIV, people who live in prisons, who might take care of other people with TB. So, this should hopefully strike a chord when we think about who is the face of COVID, right? Sure, when the outbreak first began, it was the affluent, business people, people who had the capital, the resources to travel, but very quickly it's turned into a disease that is having negative impacts far more disproportionately in communities that are socially and economically sort of vulnerable, and the people who are seconded to care for such communities. So it's much easier to stereotype, devalue, and stigmatize those members of our society. At a third level, and this is probably the most detrimental level, the stigma for TB has been fueled by sort of the systems that we have in place to deal with the disease. And we've seen this sort of cause of stigma come to life with current responses to COVID as well, right? Physical distancing, quarantine, isolation, stay-at-home orders, they can work really well from a public health standpoint. They obviously do prevent disease transmission. But if they're implemented without thinking about the inequalities in which these infections flourish, those very same measures can undermine the well-being, the social value, even the rights of people who live with the disease, causing them further sort of losses of dignity and harm. We've seen this with people getting fined, getting arrested for being mobile during a stay-at-home order, for violating a term of their sort of COVID quarantine, when they've had no other recourse, right, to manage within the confines of their compromised living situation. And this is not dissimilar to what we've seen in the history of TB disease control, with people commonly treated as suspects, patients heavily monitored, on occasion forcibly incarcerated or hospitalized to abide by these public health measures, which are justifiable in terms of protecting the public, but often fail to fully be attentive to the negative impacts that could be faced by an individual patient. So, I mean, you ask, what is the biggest consequence of these practices? So imagine, put yourself in this position. Imagine I'm this person who develops a fever, a cough, body aches or chills. I mean, these are classic symptoms of COVID. But imagine if I were living in a country or a setting that's expected to also have a high rate of TB, right? Say India, for example, say a refugee camp or a homeless shelter, even in New York. My symptoms will very quickly also be considered classic of tuberculosis. And the fear, the stigma associated with either disease suddenly becomes duplicated. So it wouldn't be surprising that I avoid seeking medical attention for my symptoms, which is, what we've heard from Dr. Firdosi and Toomey as well, and Dr. Seepamore. If I do seek care, it's very likely that I don't want to tell my doctor or nurse who I've been in contact with, or tell my family members sometimes, or my neighbors that I've, been exposed and have this illness. And this is sort of some of the main impacts of stigma that we see, right? Poor healthcare seeking, delayed health seeking, which we see in TB as well as in other disease conditions such as COVID. And this is going to be detrimental to my own health, right? Because I'm not going to get care that I need. But it's also poor infection control, which is going to be detrimental to the health of my social network. So not a good outcome at the individual or the population level. And then there's, of course, the tremendous social consequence, which is sort of ingrained into the act of stigmatization itself, like job loss, rejection, violence, all kinds of things that we've heard and seen on the news. And how do you address this type of stigma? I mean, that's $1 million question. And I'll say, if we address some of these 3 big drivers of stigma that I just mentioned, perhaps we get somewhere, right? But it requires societal effort. And I actually think that responses to the world's oldest illness, infection, tuberculosis, actually has a lot to learn from the advocacy and the outcry that we're seeing around the world's newest infection, right? I think the most impactful way potentially is to address the social roots, the sort of consequences of stigma. And if we can build up the dignity, the value, the social worth of people who are affected by these infections, through social protections, grants, assistance, material support, laws that prevent their discrimination, suddenly it becomes a lot harder to cast stigma in that direction and a lot easier for people to deflect those types of acts. But there's, I think, a lot more that can also be done in parallel. I mean, simply quell the public's fear of transmission, right? Talk about recovery, talk about the loss of infectivity just as quickly and just as often as we talk about risk and infectivity. Take away blame, discuss the non-discriminatory nature of these pathogens. They can truly affect anyone. We've seen this sort of witch hunt attitude that a colleague of mine at the London School has written about. We have to reject such a narrative. And gatekeepers, such as you and I, have the power to lead those counter narratives, right? We don't have to wait for Mayor Ford or Justin Trudeau or Ted Rose to talk about this. We can do it in our own homes, in our own communities. Normalizing the use of masks, I mean, stylize them. My hope is now every TB patient will hopefully no longer feel awkward ever for wearing a mask. Normalize social distancing, particularly in the household. We've suddenly come up with concrete, realistic strategies on how people can manage transmission within one's own household. I absolutely don't mean to say that it's preachy perfect around COVID, but this has been so poorly done and thought out for people with TB. There's been so much more investment of resources and creativity, really creative thought when it comes to COVID. I think there's so many lessons that can be learned. It's a two-way sort of street. Anyway, I can go on. I'll stop here, Amal.
Thank you, Dr. Daftary, for sharing your insight on TB stigma and how that is being increased during this time. Now we're going to shift on to audience Q&A. I would remind everyone you can switch to gallery view as it might be easier to participate in the Q&A. And if anyone has any questions, feel free to unmute yourself and ask any questions you have.
I have a question. Hi, everyone. My name's Lee. My question is, I was kind of keeping track of the chat, and participants were bringing up the resources and political will that has been paramount to the COVID-19 response. And I guess my question to any of the panelists is, how do you think that we can kind of harness this global attention that has been drawn to COVID-19 to keep the momentum going on this conversation around global health and infectious diseases more broadly, to increase awareness and action for other infectious diseases, including TB?
Yeah, I can just start the conversation. I think there's so much, infectious diseases are often managed in silos. HIV did this, TB has done it, now COVID is doing this, but there's so much crossbreeding that can happen if we sort of put our heads together. And yes, TB is affecting, a part of the world that other people may not in, our part of the world necessarily be thinking about, or communities that we're not necessarily placed in. But TB is happening in Canada as well. And I just think there's a lot of hybridization that can happen. And they're capitalize, let's capitalize on whatever is being pumped into the COVID response and take advantage of it. To strengthen health systems. I mean, HIV did this years ago. They've strengthened entire health systems in parts of sub-Saharan Africa because of the HIV response. And now they're delivering all kinds of care through those channels. And there's no harm that TB can't do that. We tend to think that everybody can learn from TB, which is great. There's a lot that TB can, I think, give to infectious disease management. But there's a lot, I think, that we can also learn from how other people are doing it and other disease control situations are sort of working in the space.
Yeah, I'll just add on to what Amrita said, Lay, is that I think one should also look at how TB has acted as the springboard for COVID. You see, COVID has not come in a vacuum. There were systems in place. There was donor funding being pumped into countries, mainly by the Global Fund. I don't know whether you are aware, but the Global Fund, which started in 2002 with Sir Richard Feacham, and up to 2018 or 2019, has raised $51 billion and has paid out $45 billion. But just for you to get an idea, Lay, are you aware of what the health budget of Ontario is? The health budget of Ontario, with a population of 14 million, is $64 billion. So the question here is, you have to think laterally. Now the problem, the thing is that the infrastructure that was already there for tuberculosis being a respiratory disease was capitalized upon in different countries for COVID. The gene expert machines were used for COVID diagnosis. As I told you, masking, treatment, follow-up, case contact tracing, etc., was done. So the only problem is that if you look at the global TB report of 2020, which is the best report on TB comprehensively, there I was looking at the Indonesia finances, and for 2020, the finances from the government basically came down to half of what it was from 2019, because they were diverted to COVID, etc. So that is where countries will have to be more flexible and look at how things can go on about that.
Thank you.
Thank you so much for your question. I see Salman has his hand raised. If you can unmute yourself, ask your question.
Thanks very much, and thanks for this session that brings attention to so many things. My name is Solomon Mokhase. I'm both the chief whip of the governing party in South Africa and in a local government in Johannesburg, one of the biggest cities in the world, and also the chief whip of government. I joined this session because one of my colleagues who have been a colleague with me and one of the intellectuals that we have around, Dumi, invited us to this session. But I wanted to ask, when we read in relation to COVID, we have seen a mobilization of the world through Organization of the World, how the World Health Body has dealt with the pandemic of COVID. And I'm asking myself, what is it that we can do as intellectuals, as people in the field of health, social development, that we can do so that they consider TB as a killer disease? If you're in South Africa, since I was born, I knew that TB is a very, very dangerous disease, and it has done so many damages in families. And I hope what has been done, because on COVID, it has shown that government can be able to respond in terms of disease. But if all government are saying there are comorbidities, which TB would be one of those comorbidities, what is it that we can do together jointly to make the World Health Organization to act the same as if they've acted on COVID, so that we reduce and be able to fight the stigma of COVID? Thank you. The stigma of TB. Thank you.
Okay, thank you. Do any of you speakers have anything to add for this?
Thank you.
I'll just say one word about the World Health Organization, because that is what Solomon talked about. You see, when the World Health Organization does something, they are blamed. When the World Health Organization doesn't do something, they are blamed. So it is a tightrope. There are many deficiencies and problems with the organization, which are being looked at, and I think it is a very good thing for the world that President Biden reversed the earlier decision to pull out of WHO. But for you to understand the budget of WHO for 1 year, which is a member state organization of 192 member states, is $2 billion, just $2 billion. So there have been many reviews which have been done recently, high-level reviews, etc. And I'm sure the Tedros will take that into consideration. But it's a difficult difficult rope to walk on. But the world goes on.
Thank you, Dr. Mehta. And Dr. Seepamore, if you'd like to add on.
Thank you so much. Yes, I did want to say that there is a political will to ensure that government TB services are conducted in South Africa. We also have universal testing, and we've got, in the public health sector, treatment is free. But I think it's not enough. We still need to do a lot of awareness. We still need to destigmatize TB itself. It's an old disease, and once people hear TB, it's as if it will be cured, you will move on, you won't die, there's treatment. But there is really that need for us to ensure that we support healthcare workers and caregivers who take care of people with TB. We also ensure that we prioritize TB and not put it in the back burner like we did. HIV came, it just went straight past TB. COVID is here, it's gone straight past TB. TB is still at the back. So we really need to put it right at the front And we need to say that this is something that can affect everyone. When, for example, the mask has, for now, has been destigmatized a bit, but not because of TB, because of COVID. And I really wish that it could have been because of TB. And just to say, like Dr. Mehta just said, TB has been here the whole time. It's laid the ground. It's made things possible. So why not acknowledge it and make sure that we really leverage on what we have? So it's not enough. It's there. I know we'll always complain, but I guess we're trying to say, when you started, Robin, World TB Day is on the 24th of March. Probably a handful of people in this webinar know that. So a lot of people don't even know, but if you ask them, when is World AIDS Day? Everybody knows it's the 1st of December. So it really needs to get a lot more visibility. Thank you so much, Emma.
Thank you. And now I'll invite Willie to speak.
Bonjour à tous, vous m'écoutez très bien? Are you listening me?
Oui, c'est bon, continue.
Ok. Bon, je suis Willy Nzungoudi, j'habite à Kinshasa, en RDC. J'ai souffert de la TB en 2001. En tout cas, c'était très grave, puisque dans ma famille, d'abord, beaucoup de gens sont morts de la TB. Ma petite sœur qui m'a suivi, elle aussi, elle a souffert de la TB, elle a même vomi du sang. Alors, la TB est considérée comme une maladie familiale chez nous. En 2001, j'ai suivi mon traitement pendant 8 mois. J'ai été guéri. Et 15 ans après, j'ai commencé à sentir des douleurs dans mon thorax. En allant à l'hôpital, on m'a diagnostiqué que... Vous suivez bien?
Oui, c'est bon, je vais traduire, continue.
Ok. Après 15 ans, on m'a diagnostiqué que j'ai perdu un poumon gauche. Donc pour le moment, je vis avec un seul poumon. Alors, en décembre passé, j'avais attrapé le coronavirus. C'était très grave, puisque vraiment, à vivre mon état, ce n'était pas facile. Heureusement que j'ai de la résilience, sinon je pouvais même mourir, puisque ce n'était pas facile. Et puis chez nous, à RDC, ce qui m'a sauvé aussi, c'est le climat. Bon, pour le moment, je peux dire que j'ai perdu mon emploi, puisque moi, mon employeur, on ne s'entendait pas. À cause de aussi, c'était le Covid, il a profité de Covid pour me mettre dehors. C'est pourquoi je veux savoir comment est-ce qu'on peut nous protéger, nous, pendant cette période de Covid, nous qui avons des effets de la TB et puis dont le virus continue à circuler toujours. Puisque pour le moment, je ne sais pas qui encore a la TB dans ma famille, qui peut nous le transmettre aussi à la prochaine fois. Comme c'est une maladie, ma famille est considérée comme un foyer de la TB. Donc il nous faut une protection puis un suivi. C'est pourquoi je lance des appels dans les organisations internationales pour nous venir en aide, voir un peu de près ma famille et puis ne pas nous laisser trop loin de l'aide internationale. Comme maintenant là, je suis sans emploi, c'est difficile de vivre.
Okay, je vais traduire. Et tu dis que tu cherches entre autres la protection contre la COVID, surtout tu veux? Ou contre une réémergence de la tuberculose?
C'est ça, les deux. Okay. La résurgence de la TB peut se manifester puisque dans ma famille, c'est comme un foyer de la TB. On ne sait pas qui en a encore, qui peut nous infecter à la longue.
Okay.
5 personnes sont mortes, 6 sont survivants, mais on ne sait pas, le virus continue à circuler. C'est pourquoi il faut un suivi et puis un contrôle permanent pour que cela ne puisse plus se manifester et mettre fin à cette maladie compliquée. C'est ça ma lutte. Okay. Merci beaucoup.
So our friend Willie is from Kinshasa. In 2001, he contracted TB. It was very serious. And his little sister was even more serious. She got to vomit blood. And really, many people got it in his family. His family became like really a sort of hub of infection. 5 were dead and 6 survived. Fast forward, he had a treatment of 8 months and was okay, but fast forward 15 years and he was back with pains in the chest and basically lost a lung, some sort of resurgence of TB, then immediately followed by COVID, which was in his case extremely serious, almost fatal in his case. And really his appeal here is that his family is at risk. He is at risk. He's even further at risk because his employer took the advantage of the COVID situation to fire him because they didn't get along that well. So it's perfect excuse. He's now jobless, and he says, how can I make sure my family is both protected against a resurgence of TB and protected against an infectious disease like COVID when it's ramping around and lurking and basically putting everybody at risk. So that was his question.
Okay, great. Thank you. Maybe Dr. Daftary, if you'd like to answer this question.
Sure. Willie, thank you. Maybe you're not able to follow me, but perhaps somebody can translate it afterwards. Thank you for sharing that story. And you know, I wish there were more systems in place to protect people who've suffered from TB, their families have suffered, and same with COVID. I think, at least in Canada and possibly in other settings as well, relatively speaking, some protections are being placed or put into place for COVID, or at least there's some acceptance or allowance for sort of, you know, absence from work or not performing or not providing for your family in the same way that you might have pre-COVID. And I think there's a lot that can be done in the TB space to really boost that protection. I sort of mentioned this very briefly in my talk, but I think that's the first place in which stigma can be stopped, is by really building up the resilience of people and communities that are affected by literally throwing resources. Because if you have the material support, you suddenly have the power to literally say no to stigma, like just stop it at the door, right? And in the absence of that, I don't want to say the stigma won't keep coming, but it will get through the door. It will get through your door. And exactly what you've described, job loss, this is all acts of stigma, right, ultimately. So thank you for sharing that. And I wish I had the answer, but I think it really behooves governments, advocacy organizations, people like people in the community like you and I to take action to the level that we can, right? I may not be able to change the president's mind or the prime minister's mind, but I could certainly change the mind of the people that I live with.
And I think this is a really good note for us to kind of shift towards a close for this session, which is all about taking action. JF, I'll let you maybe give a bit of a response to Willie by letting him know we're about to take action right now together in support of mobilizing resources to communities on a needs-based, with a needs-based approach. So we're about to do that right now. So tell him to stick around. Willie's also sent me an email that I'm gonna review and make sure that we do something with that by connecting to local resources. If anybody knows of any local resources where Willie is based, let me know. My first approach is going to be trying to connect him with some TB survivor groups that I am aware of and have relationships with contacts at. But if anybody else has any resources they can share, please let us know. So JF, I'll let you give that taken to talk about why it's so important to take action. It's because of people like Willie who need us to right now.
Yeah. I'll just give a 60-second top line summary. Alors, Willie, essentiellement, ce que nous disait l'intervenante, c'est que ton cas nous montre l'importance d'avoir des systèmes qui sont en place pour protéger les emplois, pour s'assurer que les employeurs n'utilisent pas une baisse de la performance pendant la COVID ou pendant des maladies comme la tuberculose comme prétexte pour mettre fin à l'emploi de leurs employés. On s'assure aussi de construire, si tu veux, les ressources matérielles qui sont nécessaires pour pouvoir épauler les gens qui vivent toutes les difficultés qui sont associées avec la COVID ou la tuberculose. Et Robin mentionnait que justement, on va profiter de l'occasion et de ce webinaire pour mobiliser des ressources pour pouvoir précisément faciliter cette résilience et cette lutte contre la tuberculose. Alors, je passe la parole à Robin. So over to you.
Okay. Thank you so much, JF, and thanks everyone. Okay, so I think that's a really, really good note to say thank you, Amal, for moderating such an engaging discussion, and to all of our esteemed speakers for being here today. We really do appreciate your time, and also those of you who are watching. If you've paid attention this whole time, that is absolutely fabulous. I know how exhausting Zoom calls can be. So now that we have learned a thing or two more about tuberculosis and really the urgent action that is needed to mitigate against the devastating ripple effects of the pandemic, let's do something about it together. Doing TB research or working for an organization committed to ending TB are very important pieces of what is needed to end the epidemic. However, to get the attention of and to mobilize a response from decision makers and donors that will channel ideally resources towards the tuberculosis epidemic, we need to take advocacy action because we need to create an environment in which political will exists. It can't exist if it doesn't have the likes of you and I raising our voices, exerting pressure where we can, and speaking up in support of the causes that we care about. So at Stop TB Canada and at Results Canada, we really do aim to create political will, and we equip others to take high impact action. So I'm going to share my screen, and I'm going to ask every single one of you on this call right now that has a Twitter account to do this simple action with me now, because it does and will have impact. So I'm going to share my screen. Okay, so this is the Results Canada website. We always put out strategic actions for our volunteers to engage in each month. I'm going to put this link in the chat box for everyone so that you could do this with me. Oh, goodness, sorry. Chat box. Okay, link, please go to that link. That's all you need to do right now. Go to that link. Okay. Step 2, see this tweet instantly? I want you to click on that. Just click on the copy of that tweet. And it will pull up Twitter and a new page for you directly from your account with this pre-drafted tweet, okay? So I'll give you a second to do that. Why are we asking for this right now? So TB Reach, some of you might know what TB Reach is. It's an innovative financing mechanism that was created to find the millions of missing people that we know have TB, but that just aren't getting access to the care that they need. So TB Reach is interesting in that it is small-based grants that go direct to community-led initiatives, and it's all about getting boots on the grounds to get out there and find people. Canada was a founding donor of this initiative back in 2010, and their funding is sunsetting this March. And I'm really worried that Canada might not maintain its investment in TB Reach. And if they don't maintain their investment in TB Reach, especially during a pandemic, when we know there are massive gaps in service provisions for people with TB, it will have absolutely devastating consequences. So we are asking Canada to step up and make sure that funding in TB Reach is maintained. And I'm actually just going to edit this because it's more strategic for us to tag Karina Gould in this post. So if you can, just edit this and get rid of Justin Trudeau. He hears an S from us, and put in Karina Gould, who is our Minister of International Development. I want her to know that a ton of us are expecting her to maintain investment in TB Reach this World TB Day. Okay, so I hope everybody has that done. Next step, if you want to really up your game, right click on this picture on your screen and go copy image. And then all you need to do is go back into your Twitter, make sure you're at the end of your post, and then just paste. And there you go. Now we've got this really pretty image to go with this that says something about why it's important that we invest in TB Reach right now. And I'm actually going to tag a bunch of people because I find that fun. I'm going to tag Results Canada. I'm going to tag Stop TB Canada. I'm going to tag the Stop TB Global Partnership. I'm going to tag McGill because they do knowledge management for TB Reach. I'm going to tag Matty Pye because hopefully he sends it out. He's got a big following. Yeah. And I'm then going to go done and hit tweet. And I really hope a ton of you just did that with me because it might seem trivial, but our social media engagement is tracked by our political staffers. So it is one way to quickly take action and generate noise around issues we care about. So we're going to close with final inspiring remarks for our speakers. I know we are at time, so if you have to drop off, that's totally fine. But I will give our speakers an opportunity to close with inspiring remarks so that we all feel hopeful and we all get out there and take action to end tuberculosis. So I'm going to pass it first to Dr. Daftary, and then can you pass the mic from you yourself to the others before we close?
I think this has been a terrific panel. I just wanted to say a huge thank you. Really, really good to hear from others and sort of just filter through all this information coming through. I think there's a lot to be learned. Thank you so much. And yeah, happy World TB Day. What an awful thing to say, but.
Dr. Seepamore?
Thank you so much, Amal, Robin, for organizing this webinar. I always learn something, but my just 1 minute piece is just that this TB remains the leading cause of death in South Africa. So I want to repeat it all the time so people know, and that it must be allocated as many or more resources than COVID and HIV. Also, we want to keep TB on the agenda. So let's know TB symptoms. Let's test for TB. Let's raise awareness, be engaged in TB awareness days, visible messaging, stigma reduction campaigns. Let's also support healthcare workers. I think COVID has made it clear that we really do need to take care of caregivers as well as healthcare workers. So if we can't eradicate it, but at least let's curb the spread of TB. Thank you.
And Dr. Mehta?
Yeah, thanks, Robin and Amal and the rest of the people and my co-panelists for a very interesting and engaging webinar. I'd like to close by saying that I'm very happy to see Amal as the future global health professionals. They are going to be in the future, and I'm happy that you took the initiative over here, and I hope that you will continue in infectious disease and in TB. So it's close to my heart, and thank you, and let this just be the beginning of an engagement. And I'd like to I would very much be happy to be engaged with Robin and the rest of the people working on this. Thank you.
Thank you so much. And last but not least, over to our all-star moderator and convener of this session, Amal. Everyone, please give a big clap in your emojis to her for all of her hard work she put into this. Over to you for final words and closing up shop.
Thank you all. I just want to thank everyone for joining and participating. I really appreciate it. And I really think that TB, needs to be focused on more, especially like in the future of this pandemic. And I want to invite everyone to continue raising their voice on social media. And if we can, to take a picture before we close, if that's all right with everyone. If you don't want your video to be shown, just stop your video and I'll count down. All right. So 3, 2, 1. Okay, and let me try one more time. Ready? 3, 2, 1. All right. Thank you all.
You.
Thank you,
Bye,
Amal.
everyone.
Bye.
Bye. Thank you, everybody. Thank you for this webinar. It was very good.
Thank you so much, Willie.
Okay. Bye.
Be in touch
Thank you.
soon.
Thank you very much.
Don't forget to send that tweet if you haven't already. Bye.
Bye. Bye.